So I would like to warmly welcome Professor Andrew Spencer. Professor Spencer is head of the Malignant Hematology and Stem Cell Transplantation Service at the Alfred Hospital, Professor of Hematology at Monash University, and group leader of the Myeloma Research Group within the Australian Centre for Blood Diseases in Melbourne. He has been an invited speaker to numerous international meetings on genomics, therapeutics, and disease monitoring in multiple myeloma. He serves on the scientific advisory boards of the International Myeloma Foundation and the International Myeloma Working Group, and chairs the Myeloma and Related Diseases Registry and the Australasian Myeloma Research Consortium. So great to have you with us today, Andrew, and over to you.
So, thank you very much, Deborah, for that kind introduction. So my topic today is, why is my myeloma so unique? So this is a very, very complex question. And so there's a very complex way to answer this, or indeed there's a more straightforward or understandable way to answer this. So the more complex way to do this will be to start speaking about genetics at great length, but I don't think that's really what we need to be talking about today. And so I've taken the position, I guess, to try and explain this by saying what are the various factors which impact how my myeloma behaves? Because I think as a patient, you'd be interested, why is mine behaving differently to other people and so forth? And from that perspective, I think that the way to look at this most sensibly is, in fact, to think about the disease itself, to think about you, the patient, and then to think about your treatment, because all of these things influence how your myeloma behaves. So first, if we think about the disease itself, myeloma is one of a quite complicated group of disorders, which are called plasma cell dyscrasias. And all of these disorders are characterized by abnormal populations of plasma cells. Now, plasma cells normally reside predominantly in the bone marrow, but also in the spleen and some of the lymph glands and the gut. And they're the cells that make antibodies for the body. So they're not actually made in the bone marrow, they're made elsewhere, then go and live in the bone marrow. And that's why myeloma is largely a disease of the bone marrow. And as you can see from this list, there's a whole pile of other disorders which affect plasma cells. And in fact, sometimes it can be very difficult differentiating some of these disorders from multiple myeloma. And that's one of the challenges we have with diagnosing the disease accurately and therefore instituting treatment in a prudent fashion. So here's just a cartoon of these different disorders. And you can see this is quite old data now from the Mayo Clinic. But the commonest plasma cell disorder is monoclonal gammopathy of undetermined significance. And everybody that has myeloma has had this disease before they got myeloma. So we call it MGUS for short. So you can't have myeloma unless you've got MGUS beforehand. And the differentiation between different patients starts at this level, because we know that only 1% of patients with MGUS each year will develop myeloma. So there's clearly dramatic differences, even at the MGUS level, before myeloma develops between different individuals. So the cardinal features of myeloma I've listed here. We've got anemia, kidney problems, bone problems, high calcium, the presence of that paraprotein in your bloodstream, and we'll talk a little bit more about that. And of course, the risk of infection, which Ben will address later, that's a cardinal feature of myeloma, because as you can imagine, if your normal antibody making blood cells are disrupted by this disease, you're going to be prone to infection. And that's one of the problems which patients frequently face. So before I go into that, just a picture here, this is what the bone marrow looks like with multiple myeloma. And these cells are plasma cells. And you can say to yourself, well, you know, they'll look pretty much the same to me. And in fact, that's the problem. In myeloma, they are pretty much the same in that they're clonal cells. Whereas in an individual without myeloma, the cells are what we call polyclonal, because all the plasma cells make different antibodies. So in patients with myeloma, we've got this massive expansion of clonal plasma cells, which don't really make useful antibodies. and they tend to pack out the bone marrow, leading to some of those features, which I'll describe to you in a moment. So one of the cardinal features of myeloma, and you'll all be aware of this, is the fact that it makes, in most cases, a protein detectable in blood called a paraprotein. So we look at proteins in the blood with a really old-fashioned test called the serum protein electrophoresis. And this is a serum protein electrophoresis from a person without myeloma. And you can see that there's like a smudgy thing down the bottom and then like a squiggly line at the top. And what this is telling us is that the most abundant protein in the bloodstream is this ALB. This is albumin. So this is a good protein we all have in our blood in large quantities. And then on the right side, with that little gamma symbol, there's like that lump. This represents all the normal antibodies in the bloodstream. So these are gamma globulins. And if you look down at the smudgy thing at the bottom, you can see on the right side of that, there's like a broad, dark smudge. And this represents all the different antibodies present in the bloodstream. In a person with myeloma, you can see there's a striking difference in that smudgy bit on the right has now been replaced by this band or M band or paraprotein. And you can see that the graphic above shows this big spike. And that is protein being made by the abnormal plasma cells. So you can't have a paraprotein like this unless you've got the abnormal plasma cells making it. It's a bit like smoke to a fire. And so this is the biomarker or the thing in the bloodstream that in most cases your doctor monitors to track how your myeloma is behaving. But this biomarker or paraprotein in patients is actually different in different patients because there are different forms of paraproteins. If you look at the cartoon on the left, this is just a cartoon showing what a paraprotein looks like. It's made up of 4 bits of protein, 2 big bits, 2 small bits. The big bits are called heavy chains, the small bits are called light chains. And the big bit, the heavy chain, can be in IgG, A, D, or M, and they're all different. And the light chain bits, the small bits, can be kappa or lambda. So there's all these different versions of that people can have. So there's a point of difference right from the start, that your myeloma might be making different paraproteins. And these behave differently and can have different implications. And when it comes to the light chains, some myelomas only make the light chains. About 20% of myelomas only make light chains, and that's light chain myeloma. So again, that's different to patients who've got a paraprotein. And the light chains can be kappa or lambda, and that's important as well because lambda light chains have got a greater tendency to affect the kidneys. And so again, that can change the clinical picture and make a point of difference between patients with kappa or lambda multiple myeloma. So we can actually identify what sort of paraprotein people have got, again, by one of these smudgy sort of lab tests that we do. And here you can see there's like a dark smudge on the G band towards the right. So this is telling me it's an IgG paraprotein. And then directly below that, where there's a K and an L, you can see there's a band on the kappa or K bit. So that means it's a kappa. So this is an IgG kappa myeloma. So this is how we identify what sort of paraprotein or light chains your disease is making. So the trouble is that even though we know that the plasma cells in myeloma are clonal, and that makes us think, well, they're all identical, it's actually a bit more complicated than that, in that within that clonal population of plasma cells in someone with myeloma, there's all distinct little families or patient. So if you then think about the fact that you might have 100 patients, all with different subclones of plasma cells in them, you can start to get a feel for why it is such a variable or heterogeneous disease. It can be dramatically different between individuals because of this complexity at a genetic level. And like I said, only 1% of patients per year get myeloma from MGUS. So again, highlighting the differences in patients with MGUS, who even at that stage can have these different families of abnormal plasma cells. we've done a lot of work, as have other investigators, looking at the genetics of myeloma, doing sequencing, DNA sequencing of the abnormalities in plasma cells. And this is just one example of one of the things we've looked at a few years ago, where we had a patient where we did 2 biopsies. We did a biopsy of the bone marrow, and we did a biopsy of a rib lesion, and we did the DNA sequencing of both of these lesions, and we showed that they were quite different. So even in the same patient, the disease at the same time can be different at different locations within the patient's body. So explaining to you this sort of genetic complexity. And this can sometimes underlie what we see when we treat some people with myeloma, in that in parts of the body, the myeloma will get better, but in other parts, it might not. And that's because of this underlying what we call spatial genomic heterogeneity. It can be different in different spots in the same person. So if we go back to these clinical features, I've listed them here, and we'll speak a little bit more about that now. So when you're suspected of having myeloma, you'll have a whole range of tests done, which you'll be familiar with. These are things like your blood count, kidney function. You'll have your protein electrophoresis done. You'll have certain things in the bloodstream measured, which tell us a bit about what stage of myeloma you've got. You're going to likely have 24 urine collections to look to see whether any of the myeloma proteins in the urine, and has that got implications for your kidneys. When a person is diagnosed with myeloma after those tests have been done, there are certain symptoms that a patient may have. And it's important to understand the difference between having symptoms and what a doctor would call signs. So symptoms are what the patient complains of. I've got bone pain, I'm tired, I've lost weight. Whereas signs are things that might be evident on x-rays or scans or blood tests. So they're objective things which are measured. So when we look at the symptoms that patients might have, you can see here the commonest symptom is bone pain. So 58% of patients in this publication describe bone pain, but that means that 42% didn't have bone pain. Similarly, a quarter of the patients here had weight loss, but 3/4 didn't have weight loss. So right from the beginning, patients can have different symptoms when they present with their multiple myeloma. And then this is borne out when we look at these signs or clinical features. So as expected, most people will have a paraprotein or M protein. When we do x-rays and scans, we see that about 2/3 of patients have got evidence of bone lesions, which we'll describe in a minute, but that means 1/3 of patients don't. And some patients actually never get bone lesions. So again, this is an important reflection of the fact that the genetics of the disease in patients can be quite different. A lot of people get anemia because those plasma cells are invading the bone marrow, but a quarter don't, because some people actually don't necessarily have a lot of plasma cells in the bone marrow, but still have multiple myeloma. So again, these features can be very different between patients. So these are some x-rays of a patient with multiple myeloma. You can see these little holes, these dark areas in the bone. These are what we call lytic lesions or punched out lesions. And these are due to areas where there's lots of these abnormal plasma cells within the bone marrow. And in fact, when the first archaeologists started digging people up in Pompeii from ancient Rome, they found individuals with lytic lesions in their bones there, telling us that myeloma has been around for a very long time. It's not just a disease of modern people, it's been in humans for thousands of years. So these lytic lesions are a cardinal feature of the disease, and some patients have them and some patients don't. One of the things that can happen when we've got these sorts of lytic lesions developing is that they can occur in parts of the body that are critical. So for example, if we have a lytic lesion develop in the vertebra, that can cause a lot of trouble in relation to the spinal cord. So some patients may be unfortunate enough to have vertebral lytic lesions, whereas other patients won't. So again, there's significant differences between individuals. So what are the different bone lesions or SREs, skeletal related events that patients can get? So we can see fractures of the bones, we can see damage to the spinal cord, there may be a necessity for radiation treatment to lesions, there may in fact be necessity for surgery. So often we will call our orthopedic colleagues and ask them to look at maybe one of the leg bones and say, does this need something doing to stop it breaking? So people sometimes will have prophylactic operations where metal rods are put in the bones to strengthen them, to stop them breaking. So all these different features are features of the bone disease in myeloma. So again, if you mix and match these different things, you can see how there can be a dramatic difference between patients, depending how their particular disease is behaving. Now, speaking about the patients themselves, okay, we know that myeloma is a disease largely of older people with an average age of diagnosis around 70. But here, this is some data from the UK. It's old now, but nevertheless, it holds true. Is that you can see there are young patients in their 30s and 40s with multiple myeloma, and then patients in their 50s, 60s, 70s, 80s, and so forth. So again, you can imagine you've got the variability in the disease itself, but then you've got the variability between the patients that actually have it. And the age of the patient has a significant impact on how the disease will play out. So this is some data from the registry that I've been involved with for a number of years. And this is looking at survival in myeloma in Australia. This is in real world patients. This is not in patients on clinical trials. So you've got to keep in mind that this data relates to therapies that we've had before we looked at this. It does not tell us about what these newer therapies will do to survival. So this sort of picture is constantly changing. The thing to keep in mind here is that the blue line is patients who are under the age of 70 with myeloma, whereas the red dotted line are patients over the age of 70. And you can see there's a significant difference in outlook for patients depending on age. And this is not driven largely by the biology of the myeloma being different in young and old, although there are some differences. It's driven largely by the fact that older patients have got more significant health issues. So they might have heart disease, lung disease, they may have pre-existing kidney disease. And all these things will impact on how well the patient tolerates the diagnosis of myeloma and what it's doing, but also how well the patient will tolerate treatment. So it's a lot easier to treat a 45-year-old aggressively for myeloma than it is a 75-year-old. And so these are differences which impact on how the disease behaves and the outcome of the disease. So we've studied very closely what factors, patient-related factors, impact on outcome. And what I wanted to show you is just these bits in red. And if you look at this table here, under the heading odds ratio, there are various numbers. So this number, if it's above 1, means that the characteristic to the left, so age or performance status, is bad. So if you've got an age over 75, the odds ratio is 3.1. So that means that you're far more likely to have trouble in controlling and surviving your disease than someone who's under 75. Similarly, if you go down the table, look at cardiac disease, pulmonary disease. These are problems which are increasingly common as we get older. You can see the odds ratios there around about 2 or 2 and a bit. So these factors impact on outcome for patients, largely because it impacts on how you can treat the patient. So these different patient characteristics also add to why the disease in an individual can be quite unique. It's not just the disease, it's the patient themselves, and that dictates what you can do or cannot do in terms of treating the disease. Now we know the disease it's interesting in that it will respond to treatment, but then after a variable period of time, it will relapse. It invariably relapses. And I've seen patients where this relapse may be within 3 or 4 months, or it may be more than 10 years down the track. And this is in patients who receive the same therapy. Now, in that case, that's driven by that underlying disease biology. So out of all the myelomas that we see, there are some which are good versions of a bad disease, and then there are versions which are bad versions of a bad disease, and that's the genetics underlying the disease. And that really determines the duration of response to treatment, or everything else being equal, people getting the same treatment. So these days in Australia, the major decision about managing myeloma boils down to whether someone's transplant eligible or not transplant eligible. So in patients who are transplant eligible, they'll have some form of what we call induction therapy to control the disease. Then they'll have a transplant. Then they might have a bit more therapy, and then they'll have some maintenance therapy. In patients who are not fit enough for a transplant, they just get treated with similar therapy to the induction treatment that the first group of people get, but then it's continued on in an ongoing fashion, usually then followed up with some form of lenalidomide maintenance. And there's various drugs which are available for newly diagnosed patients, albeit in a limited fashion. And these are generally used in a similar way, both in younger and older patients. The difference is the transplant thing. So what about response to treatment as the final arbiter of uniqueness between patients? Okay, so this is some data from my department at the Alfred Hospital. And some of you would have heard about the fact that now we're moving into the realm in myeloma of needing really sensitive tests to measure what disease patients have, because their paraprotein's gone, their bone marrow looks normal. So we now have super sensitive tests which measure what we call minimal residual disease. And we've been doing this for a number of years here with a test called Euroflow, which can pick up one myeloma cell in 100,000 normal cells. So if this test is negative, it means there's less than one myeloma cell in 100,000 normal cells. So very low tumor burden, and that's minimal residual disease negative. And the graph here shows you the impact of that. And the patients on the green line are patients who have achieved minimal residual disease negativity and gone on to maintenance therapy. And so they're all staying in remission as we follow them up. The unfortunate patients on the red line have not achieved minimal residual disease negativity and didn't, for whatever reason, go into maintenance therapy. So you can see that the response to therapy and the interaction with ongoing therapy is a huge determinant of how the disease behaves. And if all things are done in an optimal fashion, we can't really do more than that. So what I'm saying is that if everything is done properly, right therapy, right doses, right sequence of therapies, that's all you can really be asking for in terms of how to get things in control. And then there are some factors which are intangible, which we can't change, and that's the underlying biology of the disease. So from your perspective, what you have to ensure is that you're getting the right therapy in the hands of the right person looking after you to make absolutely certain that you're getting the most bang for your buck, if I can call it that way, for the therapy that you're getting. So there are disease characteristics, there are patient characteristics, and then there are treatment variation in response to treatment, all of which impact on how your myeloma behaves. And we only have control over some of those elements. And that's why you can have a room full of people with myeloma and it's all behaving differently, doing different things, because it's a very complex interaction of all these different factors. And I think that was my last slide. So I'll finish there, and I'm happy to take any questions in relation to that, or indeed anything else that pops into your mind. Thank you for listening.
Thank you, Andrew. Look, that was terrific. You've explained extremely well the uniqueness of myeloma, you know, it being so complex and how changeable it is between people. And you even talk about, you know, the DNA sequencing and it presenting differently in the same person in different locations in the body. This all must make it incredibly difficult to treat person to person. Can you expand on that?
Yeah, look, one of the real issues I think a lot of clinicians have with myeloma is that, for reasons which I won't go into, it's the wrong forum, but for reasons, we treat everybody the same way basically when they first present, apart from transplant versus no transplant. And this really belies the fact that we know that there's massive variation between patients in terms of their prognosis. And that's largely because there's a limited armamentarium of therapies available where we live for newly diagnosed myeloma. So it's not like we can go to the cupboard and we've got a dozen different medicines and we select which ones are best for the patient, you know, which will be a more personalized approach. I think that time is coming, but at the moment, clinicians are very, very cognizant of the fact that we're treating Fred the same way as Bill, and we probably know that we shouldn't be treating Fred the same way as Bill. But at the moment, therapeutically, that's the situation we're in. But I think it's going to be changing. So what we do initially with patients is basically treat them in an optimal fashion with what therapies are available. The one difference there is perhaps if we've got a very elderly patient where we may adopt an approach where we say, well, we'd like to treat this and we'd like to keep the patient on treatment, but we want to really make sure it's not too toxic. Because a critical factor is actually keeping people on treatment. If you stop it too early or dose reduce too early, that impacts very badly on outcome. So there is some variation depending on frailty. We've got a clinical trial looking at that we're running at the moment, trying to, you know, optimize treatment for frail patients. So everyone gets treated the same, perhaps except for that frail group of patients who can't tolerate more standard treatment.
Thank you. And we are all heartened. There are new therapies, you know, coming out all the time. Peter has a question. So with smoldering myeloma, he says it's really hard to sit still and wait for the inevitable. So if we have smoldering myeloma or MGUS, is there anything we can do to prevent it moving into myeloma?
Okay, so there are a couple of points to be mindful of. If you've got a group of people with MGUS, for all of those patients to get myeloma, they'd all have to live for 100 years. So the first thing to keep in mind is only a small proportion of patients with MGUS ever develop myeloma. So you've got a far greater risk of, unfortunately, getting some other horrible disease as you get older. Okay, with smoldering myeloma, there's a lot of debate about, well, is there a proportion of people with smoldering myeloma that should get treated that have got high risk smoldering myeloma? Okay, you know, they're sitting on a time bomb. These people are going to get myeloma. But the models to identify patients with high risk smoldering myeloma are actually very poor, in that people with and without high risk smoldering myeloma can get myeloma, but they may not. And in fact, only about 50% or so of patients with smoldering myeloma will get myeloma. I know that sounds like a lot, but it means a lot of those people, like the MGUS patients, won't get it. So it's not inevitable. And I think you must be understanding of that. And I think it's also important to realize that even if we had a range of drugs available to treat smoldering myeloma, the challenge is that, as I've said, we can't identify who should and should not be treated accurately. And that raises the possibility that a large number of patients with smoldering myeloma will be getting treated with very expensive, potentially toxic drugs when they're never going to need that. So the real challenge with smoldering myeloma is understanding who's going to get active or symptomatic myeloma. And unfortunately, we're not in a position where we can do that yet. But again, there's a lot of advances being made in that space. But I think you must be mindful, this is not an inevitability, whether you've got MGUS or smoldering myeloma.
Thank you. Thanks for that. Pauline asks, do PET scans identify different areas affected by myeloma? Would it help decide what treatment is most suitable?
Okay. So, if you've got newly diagnosed myeloma these days, you may have a CT scan of your body, what we call a whole body low dose CT scan, which is a super sensitive way of looking at the bones. It's great. But that just tells you about the anatomy. Is there a bone lesion or isn't there? Doesn't really tell you anything else. A PET scan is a functional test. It actually tells you where there's areas of active myeloma disease, which may or may not correspond to those lesions you see on a CT scan. So they give you quite different sorts of information. One sort of structural and one sort of functional. And PET scans will highlight myeloma present in the bone marrow. It can also detect areas of myeloma that is growing outside the bone marrow, what we call extramedullary disease. In most cases, a PET scan at diagnosis is not going to change how you're managed. It's going to be just a piece of information at the time of diagnosis, which can be looked at later on. So you have a repeat PET scan. Has the PET scan now normalized? Or is there a problematic area of disease that's not responding, for example? Or at the time of diagnosis, in some instances, is there an area of disease visible on the PET scan which might need some radiotherapy or localized treatment? But largely speaking, a PET scan will not change how you're managed if you're newly diagnosed with myeloma. It just presents a very sensitive and sophisticated modality to gauge the extent of the disease and to look at the response of the disease. So it's just a new way, a more sensitive way of monitoring the disease combined with your blood tests, basically. It's a great test, but it won't necessarily change how you're managed.
No, understandable. There is another question from Donna. She asks, what is your opinion on stopping lenalidomide maintenance after 3 years due to the risk of other malignancies?
Yeah, this is highly contentious. I was on what's called the Safety Data Monitoring Committee with a French study that studied maintenance lenalidomide. And that study was happening at the same time as an American study. And there were subtle differences in the treatment they used in France compared to the Americans before maintenance started. And the French pulled the plug on their maintenance, saying it should only be given for 2 years because of the risk of second primary malignancies. Okay, and that's quite valid. The Americans, however, say no, you should continue the lenalidomide until progression. So 2 very different opinions from clinical trials. So the issue here is complicated in that nobody should stay on maintenance lenalidomide, in my opinion, if it's having an adverse effect on their quality of life. If you're miserable taking lenalidomide, you shouldn't be on it. It's better off for you to be feeling well and doing what you want to do rather than taking a drug which should prolong your remission, but may not in your case because of the underlying genetic variability I've mentioned. The other thing is, I was involved in some work quite a long time ago looking at this issue of second primary malignancies. Okay, now this sounds somewhat silly, but if you succumb to your myeloma, the issue of whether you're going to develop a second primary malignancy is completely irrelevant. Because the big fish that you have to fry if you're diagnosed with myeloma is the myeloma. It's by far and away the biggest risk to you and your survival. And in fact, using lenalidomide, irrespective of the risk of second primary malignancies, results in a better outcome because the myeloma is the biggest danger It's not the risk of another malignancy. So it's a complicated issue, but, you know, should you worry about myeloma now or something down the track? Well, I think you should worry about myeloma now, to be frank. The duration of therapy is highly contentious, but I think if you're tolerating lenalidomide maintenance therapy, you should stay on it. If you're not tolerating it, you should stop. As simple as that.
And I think you bring up a very good point, people staying on things and perhaps it is making them very unhappy and they're not well on it, and raising that with their hematologist and not being able to tolerate a drug. It's quality of life, isn't it? And
absolutely.
Absolutely. One more question, I think, before we go to our break. Somebody asked, does having renal symptoms make my prognosis worse?
By that, I think you probably, if your kidneys aren't working as well, does that make my prognosis worse? I guess the short answer is yes. But largely these days, because if your kidneys aren't working properly, it can impact on some of the drugs that are used or what dose of drugs are used. Because the kidney not working normally has no bearing on how the myeloma behaves. It's actually one of those patient factors I was referring to. So a patient whose kidneys aren't great compared to a patient who's got normal kidney function, well, that's going to impact on treatment. So sadly, yes. In fact, we've got some patients here that have ended up having kidney transplants to restore normal kidney function. And the driving force there has been that we've convinced our kidney transplant doctors that if these patients have got restoration of their kidney function, they'll have far more options therapeutically down the track, including going on to clinical trials. So, yeah, unfortunately, yes, it will impact on how the disease can be managed, but it doesn't affect the disease per se.
Well, Andrew, thank you so very, very much today, taking time out of your busy schedule to inform us. And it's been a great talk. Thank you so very much.